Good morning. It's wonderful to share this time with you guys. Like everyone else, I've been very impressed with the Leadership College, and this has been a very positive experience and a learning experience. And sometimes teaching an old dog new tricks, I guess I'm that old dog, but hopefully my presentation will be as slick and professional as my colleagues have been. To start, I wanted to think about what it's like to be on the receiving end of healthcare rather than as a practitioner. And I've spent my time being a physician. As I get older now, I'm interacting with my colleagues, and I think it's always interesting to see how we perceive things as patients. And that was my interest in doing this project. I would like you to imagine what it might feel like to be cold, thirsty, hungry, anxious, and semi-naked. You're waiting for your colonoscopy. I recently had my colonoscopy, and so this was a poignant point to me as a gastroenterologist to see it from maybe another perspective. And what I was interested in is, there we go. This is obviously a pre-COVID waiting room. No one is doing this these days. We're sitting in our cars outside waiting to be called in. But what I learned while waiting and how the waiting experience may impact how patients perceive their interactions with healthcare was my topic that I chose to look at. And we all experience waiting in many situations in our life, whether it's in the grocery store. Which line do you pick? And it always seems the line you pick is the one that moves the slowest. When you're at a theme park, and you're waiting with your family, excited to go on a ride, and you get to the top of a long snaking line, only to find out there's another line beyond that. And how that can frustrate and develop anxiety and affect kind of how the subsequent interaction plays out. In healthcare, this is really, I'll come back to my daughter's at Carolina, and I think through this COVID, as everyone has explained, I think a lot of people have found this a challenging time. Is it 2021 yet? Was the Daily Tar Heel cartoon. So I chose to look at correlation of wait times with patient satisfaction. And this has previously been studied mainly in outpatient clinics, ambulatory clinics, and emergency rooms. And there's very little data looking at more procedural-based waiting times in patients who are coming to an ambulatory surgical care center or even an endoscopy center. And waiting obviously can impact our perception of quality. If we wait a long time, we may feel that our time is not valued, the practice or facility may not be very efficient, and that maybe the care we're getting might be too suboptimal. Obviously, if things are moved too quickly, you may feel rushed, may not feel the time to express the concerns and questions you had, and you're in and out before you can really get satisfactory explanations to your issues in question. Wait times may also impact, we're experiencing more and more social media and Google reviews, there's health grades, patients can now look up physicians and caregivers and see what others have commented on, and this may impact referrals, and even in some models, compensation is affected by patient scores and bonus structures. So it does also have an economic effect on practitioners. And then lastly, how does wait time impact compliance and follow-up? If patients have a negative perception, are they less likely to be receptive to your suggestions? Will they not follow through on your care plan? And they may not come back. They may just feel that that was an exasperating experience. So waiting is an important factor, I think, in analyzing how effective we can be as healthcare providers. I chose to look at a study. I work in a 7-physician practice in southeastern North Carolina in Wilmington. And we have an endoscopy committee that meets usually quarterly. It's composed of physicians, nurses, administrators, and an independent physician sits on that board. I presented this concept, and it was approved. The study was designed as a survey. I'll talk a little bit about the survey itself, but it was performed pre-COVID. I was fortunate in my timing, not that I had any great insight into a pandemic that was going to hit us in 2020. but my study was completed by early March, and we were affected by COVID in mid-March as a community. It was a structured survey that was given to all patients. It was in English and didn't provide another language. And the surveys were then subsequently collected when patients were being discharged. And we, over about a month, got 187 survey replies. The survey asked patients to evaluate how they felt about the waiting, and it was in a standard format of strongly agree, neutral, disagree, and strongly disagree with the statements. And we looked at our waiting room time, the time that patients are in pre-op or holding area where they get undressed and have an IV started. Then they're obviously in the procedure space, which they're not obviously aware of, and then in the recovery area. And we also asked them to review the door-to-door time, the whole time they spent in the facility. And then lastly, we asked them what they felt was a reasonable wait time. And the first slide, there's a lot of information, but if you could focus on the right side of the slide, again, the question was the time I spent in the waiting room was acceptable. And the part that I'm going to focus on is the disagree and strongly disagree. And about 4 to 5% of patients felt that their wait times were prolonged. What I find interesting about this slide is divided anonymously from Dr. A to Dr. G, and these are the physicians in our group. But there was one patient who waited 10 minutes in the disagree column, and they felt that was too long. But in general, as patients waited longer, that was when you start seeing patients feeling maybe some frustration or anxiety about their waits. The second area is in our pre-op area. And again, similarly on the right side of the slide, about 5% of patients experienced where they felt the wait was more than they thought was reasonable. And again, these wait times were longer. The third area was the recovery area. And interestingly, this is on the right side of the slide, no patients felt that this was prolonged. And this may not be surprising since this is independent of the facility, the providers, or the staff. This is really more of a patient-driven metric when patients have recovered and feel they're awake and the nurse is satisfied that they're stable to be discharged, they can leave. And so usually there's not as much delays in this area. So I don't think that was unexpected. And then we asked door-to-door time, and I think this was maybe a little bit more helpful. We asked patients whether that was acceptable, whether it was lengthy, or whether they felt rushed. And about 4% of patients felt it was lengthy. And if you look at the bottom of the slide, it was about 128 minutes was the average for the patients who felt that it was an adequate time. And that's around 2 hours, obviously. But patients who it was only 30 to 40 minutes longer, those patients, I think, started expressing more dissatisfaction with their experience with the process. Also, it was interesting, there was two physicians, Dr. A and Dr. F, and this wasn't the purpose of the study, but they seemed to reliably have longer wait time, I should say door-to-door times. They had maybe 20-minute longer times. I don't really have an explanation. One is a newer physician, but the other physician has been in the practice for many years. And that's something we may look at in the future just to analyze that, but that wasn't the purpose of this particular study. Then interestingly, we asked patients what they felt was a reasonable time. And patients in general felt they should wait less than 30 minutes was about 85% of the responses. And what I thought was interesting was that about a quarter of patients, around 22%, felt they should wait less than 15 minutes. And that may be an expectation thing. Is that something we should maybe communicate how this process works? And that may be a failing on our part to explain the process or how this is going to play out, so to speak. So in summary, about 95% of patients were satisfied with the waiting experience, 100% in the recovery area, but about 5% of patients, which is a group we're kind of interested in looking at, were dissatisfied. So studying this group a little bit more in detail, what was playing out here? And it was longer wait times were a factor, but they weren't the only factor that was playing a role here. And in the survey, we did give a spot for people to write in comments about what other factors were affecting their satisfaction with the process. And the other factors that patients noted were interesting. Some of them were obvious, some of them less obvious. Some of them included things like amenities available. People wanted more magazines, they wanted more televisions, someone wanted the TV louder, although I know that might frustrate other patients. One thing we did come across was the temperature, and I think this is probably in the pre-op area where you're undressed. But some patients felt it was too cold and asked for warm blankets. I like the quote that someone mentioned was, "You all have it so cold in here you could hang meat," which I think leaves no confusion about how that person felt about the temperature. It's always interesting living in a rural North Carolina area. Other things such as internet connectivity, I think we could improve on, maybe giving workstations, and this is more focused on drivers. And then lastly, refreshments, which obviously in a process where people are fasting, you might think is contradictory, but I think these were people more reflecting on their drivers, and maybe if there was more amenities for those people. So how can we apply this? Obviously, this was in a GI practice, but I think it's also generalizable to any clinical situation. And I think our aim is how can we improve satisfaction in a setting where we don't control all the factors and there may be uncontrollable delays during our schedules. And my call to action is twofold mainly. First is how can we minimize wait times by better communicating schedule changes? And more importantly, do we need more dynamic scheduling? We have scheduling templates. They're kind of set in stone, so to speak. From doing this study, we've found that maybe we need to reflect, and maybe some people need different templates. But more importantly, we don't have a good mechanism to communicate early if there's a problem or delay in the schedule. And thoughts we've had are things such as text messaging and apps that might allow patients before they arrive to the facility know that their scheduled time has been changed. And I think giving patients more power in the situation and a feeling of control could be helpful in alleviating some of the anxiety and frustrations patients feel when they come. Also in the holding area, similar to what you might have in an airport where you have a monitor that shows where you are in the waiting queue, so to speak. That might also be another way to help communicate more kind of live, updated information. That I think is one aspect, and I think that's generalizable to any other clinical situation. And then the other aspect of this is thinking about the whole holistic waiting experience and that process from when you arrive to when you're in the facility to when you leave. And we've looked at maybe other ways to improve either the waiting environment, but more importantly, to provide more amenities and ways to engage with patients so that they can feel productive while they're in that space. I think is also interesting. And lastly, I do need to acknowledge a team that helped me put this together. Sherry Potter and Tracy Palmatier are our nurses who helped manage the endoscopy unit. Kira Henihan was my critique and grammatical and structural, gave me a lot of good feedback on my paper. And Dr. Jerry Matson spent some time with me and was kind enough to review the paper and maybe make it more readable and help maybe structure it a little bit better. And then lastly, like everyone else, I would like to thank the whole team at the Leadership College, both Larry, Jerry, Tina, and Aubrey for putting this together through a pandemic and allowing us to still have this incredible experience. My last slide is going to be a little joke, and it's kind of hard to see because I cropped it there, but it's a waiting area with two forlorn individuals. Thank you for suffering in silence. So I appreciate you listening to me, and I'd be happy to answer any questions on this project.
Thank you so much, Dr. Henihan, for this important work and obviously lifting up and asking for the voices of your patients and to help improve that process. Any questions that you have? While people are thinking of questions, I had a question. I was curious, of the people that you surveyed, have you followed up and shared with them some of the improvements that based on their feedback? Have you shared with any of those specific patients or in general said that we have surveyed and made some changes? Have you directly kind of shared that back? I know they were anonymous and different things. Like, how have you communicated
Yeah,
back to patients?
that's a great question. Right. I think that what we actually did, recently presented it to our group as such to kind of reflect on this, but we haven't actually identified how to kind of communicate that with patients. But I think that's an important thing. I think the message really, what we learned from this was just to think about that whole, like I described, the holistic approach to the waiting area. But more importantly, we're trying to figure out more dynamic scheduling and communication tools. And that's not as easy as it may sound. There's just not a lot of products out there designed for this. We have an IT person who's been helping us with it, but so we're still a work in process. And then the other, I think, weakness of doing any of these structured surveys is this was done only in English. So, other communities are not native English speakers. We obviously miss on those. And then also people who are either illiterate or functionally illiterate, which, as you know, could be a third of our population, especially in a rural setting. And those patients, probably their voices aren't being heard. So this is, I think it's an introductory. It was a survey designed to look at that. But I would certainly be open to ideas about how to maybe make it more diverse survey tool. Because we do have obviously Hispanic population, but we also have a Southeast Asian population. And so I think just thinking about that and how to better get feedback from those communities would be helpful.
Thank you. Yes, I think those are excellent points, and just catering, not catering, but understanding and making sure those perspectives are included. I see something from Dr. Biola was asking, is there a standard amount of time that scopes should take?
Yeah, that's a great question. We're part of a collaboration with a bunch of other ambulatory endoscopy centers, and there's no standard, but the average when we look at, I think there's maybe 80 practices in this, is about 2 hours. Some maybe do an hour and a half, some may take 2.5, 3 hours, but in general, that's the time frame that most practices seem to operate in. And so we're kind of in the middle of that timing. So I think that's the data that we have.
Okay, great. And in the interest of time, I know Dr. Biola had another couple of questions, and maybe we'll encourage you to have some comments and we'll move on, just because I want to make sure we have enough time for everyone. But thank you so much. And Dr. Biola and Dr. Henihan, I'll encourage you guys to talk.